My name is Chani Parikh, and I'm a postdoctoral fellow and a LEN trainee at the UC Davis Mind Institute. And today I'll be talking about the prevalence of internalizing and externalizing symptoms in children with and without autism spectrum disorder across two different developmental time periods. This is just a LEN HRSA disclaimer. So we know that autism spectrum disorder is a lifelong neurodevelopmental disorder with an early onset of symptoms emerging from 6 through 36 months with characteristic deficits in social interaction, communication, and restricted repetitive interest. These primary core symptoms can be further exacerbated by behavioral and emotional challenges such as irritability, aggression, hyperactivity, mood, anxiety. And previous studies have shown that co-occurring mental health conditions are more prevalent in the autism population than in the general population, such that psychiatric comorbidities in children and adolescents with ASD have become the rule rather than the exception. And as you can see, as shown by the graph on the right here, depicting the lifetime prevalence of psychiatric disorders in children. However, reported prevalence rates of co-occurring mental health conditions can vary based on how that sample is gathered. For instance, in clinics where individuals are specifically seeking clinical services, rates tend to be higher in comparison to epidemiological or population level data. In these population-based studies, the aim is to answer research questions for the defined populations where findings are more generalizable to the whole population rather than just the individuals included in the study. And it is within these individual population-based samples that we see that prevalence rates for individuals with autism range from 40 to 70%, or with ADHD, anxiety and mood disorders, and oppositional defiant disorder being among the most common. In prospective longitudinal studies that follow first-degree relatives of individuals with autism who don't themselves have autism have shown to be at a heightened risk for a variety of developmental difficulties. And this has been shown across studies for both using behavioral and neurobiological data. There are two things, however, that make identification of comorbid symptoms, psychiatric symptoms, and disorders challenging. One is that there's some overlap in shared symptomatology across psychiatric disorders. For instance, reduced eye contact is a hallmark symptom of autism. However, it can also be related to depressed mood or anxiety. Another shared symptomatology example is using, interrupting, or intruding on others. For instance, this could be related to not understanding certain social norms in autism versus interrupting due to ADHD-related symptoms. Second challenge is that there's also significant diagnostic overshadowing. Now, this is where ASD-related symptoms are either attributed to a co-occurring disorder, or conversely, considering emotional and behavioral symptoms as part of ASD rather than a comorbid symptom itself. So given what we know from the literature about the high rates of psychiatric comorbidities in ASD and in their first-degree relatives, the goal of this project was to understand the prevalence of internalizing and externalizing behaviors among children with ASD and compare it to children without ASD at high and low familial risk across two developmental periods. So the current data come from a larger prospective longitudinal familial risk design, where familial risk is defined with high-risk infants having an older sibling diagnosed with autism and a younger sibling, or in a young and low-risk infants are defined as having no familial risk for autism. And we have been collecting data since 2003 and studying these children shortly after birth and following them all the way to school age years, where the oldest children in our study are now approximately 16 years old. Today, I'll be focusing on a single measure called the Child Behavior Checklist, the CBCL, which is a well-established and widely used parent report measure with good psychometric properties to detect behavioral and emotional problems in children and adolescents. So the parents in our study completed the CBCL at two time points, once at age 3 and once again at school age. And the preschool and the school age CBCL forms have significant overlap. The CBCL has higher order factors of internalizing and externalizing behaviors that consist of these syndrome-specific scales. The CBCL raw scores were then transformed to age-normed internalizing, externalizing, and total problem T-scores, where T-scores below 60 are considered to be normal, and T-scores above 63 are considered to be in the clinical range. We also defined outcome groups at 36 months, where all children were defined as either meeting criteria for autism or not, using DSM-5 criteria and an ADOS-2 score above the ASD cutoff. These groups were further divided into high risk and low risk, where again, high risk recruitment group indicated that they had an older sibling diagnosed with autism, and low risk recruitment meant they had no familial risk for ASD. And these non-ASD high risk, low risk groups were inclusive of typical development, language delays, ADHD concerns, broader autism phenotype, etc. So first, I'll present the results at age 3 for the CBCL internalizing, externalizing total problem behaviors across the 3 outcome groups. And these percentages are shown here are within outcome groups. So what we see is that within each outcome group of ASD and non-ASD high risk, low risk groups, majority of the parents are reporting scores in the normal range on internalizing, externalizing, and total problem behaviors. And this is at age 3. When we look at school age, again, you see across the different outcome groups, the percentages, majority of the groups are once again scoring in the normal range on internalizing, externalizing total problems. However, the ASD group has the highest rates in the clinical range, and these rates are in fact much higher than they were at preschool, which is also true for the other 2 outcome groups. And this is consistent with what we know about how psychopathology develops over time and the emergence of pathology within the adolescence years as children adjust their behaviors to increasing social and environmental demands. Next, I wanted to test for mean differences between outcome groups. So again, the outcome groups of ASD and the 2 non-ASD outcome groups of high risk, low risk, and the CBCL T-scores at age 3 and again at school age. And as a reminder, the T-scores below 60 are normal, and they're shown here by the dashed line in black. And what we see is that across all 3 CBCL internalizing, externalizing, and total problem behaviors, the ASD group, despite having mean scores in the normal range, they differ significantly from the 2 non-ASD groups of high risk, low risk, as shown by the red asterisk. And this is at age 3. When we look at school age, what we see is that there were no group differences found between the ASD and the 2 non-ASD groups on the CBCL internalizing behaviors. However, on the externalizing, the ASD group and the low-risk non-ASD group did differ. On total problems, the ASD group's T-scores significantly differed from both non-ASD groups. And given what we know from the literature about the heightened risk for developmental and behavioral difficulties in first-degree relatives of ASD, surprisingly, there were no group differences found between the 2 non-ASD groups of high risk and low risk. Next, we wanted to see how well children's 36-month CBCL T-scores did in predicting their school age CBCL scores, while also controlling for their age at visit. Now, this is because school age could range for anywhere from 6 through 16 years. And overall, what we found is that children's 36-month CBCL T-scores across all 3 factors are significantly predicting their school age scores. And specifically on the CBCL internalizing behaviors, you see that 36 months are predicting their school age scores even after controlling for their age at visit. So what this tells us is that parents are reporting their children's emotional and behavioral problems as consistent across the 2 developmental time points. In conclusion, the current study has 2 non-replication findings from the previous literature. In this high-risk infant sibling design, parents are reporting their children's emotional and behavioral challenges as being within the normal ranges relative to the normative sample. So although we found significant differences in the mean CBCL scores between the ASD and the 2 non-ASD groups, and that the scores were in fact higher in the ASD group, majority of these children are still within the normal average range. The second non-replication finding is that the high-risk non-ASD group did not differ from the low-risk non-ASD group, despite knowing elevated rates of psychiatric symptoms among their first-degree relatives of individuals with autism. And one of the reasons for this non-replication could be the CBCL measure itself. For instance, the CBCL has been proposed primarily for screening for broader psychopathology in clinical settings, rather than for evaluating behavioral emotional problems in comorbidity with ASD, such that it might be difficult to distinguish how much of these clinical scores on the CBCL are affected by core ASD symptoms versus comorbid psychiatric emotional behavioral problems. Third finding for this project was that reporting of internalizing and externalizing behaviors by parents at 36 months of age are significantly predicting their school age scores 3 to 10 years later. And when we look at this at the group level, this is important because children who are showing clinically significant scores at 36 months, they're likely to be showing clinically significant scores at school age. And this can have implications for intervening early in terms of emotional and behavioral challenges. So given the non-replication findings from the current analyses, one of my future goals for this project is to look at the correspondence of emotional and behavioral symptoms across multiple measures, as well as informants. So for instance, not only using the parent report CBCL, but also using another parent measure called the CASI, which is the Child Adolescent Symptom Inventory, as well as conducting a clinician-based interview called the KSAT, in order to look at these behaviors more closely. In fact, in data not presented here today, when we do look at examiner-rated outcomes at school age visits, which is using examiner's clinical judgment and behavioral observations, we do see elevated rates of psychopathology among the high-risk non-ASD group, suggesting a need for closer evaluation of these behavioral emotional profiles. I would like to thank all the families that have participated in this study, the Infant Sibling Lab, the funding agencies, the LEND program, as well as you for your attention.
This is Len. I've got one question. It was a great presentation, Chandni. Thank you so much. And you probably haven't had a chance to look at this and maybe can't with the sample size, but this goes back to one of the questions that was asked about anxiety. Do you know if there's any interaction or if you stratify your group by IQ or verbal level, whether you see any different findings?
That's actually a great point, and one of the main reasons we're moving this. When we look at this data, I do want to look at other sort of, their verbal abilities at 36 months, as well as their IQ at school age, in order to consider if that's something that's going to influence, children's outcomes as well. Because we've seen that in previous literature, they have had factors where they've looked at IQ as being an important contribution to anxiety, as well as ability for psychopathological behaviors and reporting of those behaviors as well.
Okay, could I ask a second question? Sure. Were you surprised? I mean, given the previous presentation about anxiety, the fact that I think in your slide you didn't see any difference in internalizing behavior between the group of people with autism and the other groups, do you think that's just because, did you kind of lose that by looking at the internalizing and not taking subdomains, or do you have any sense of that?
I do think it could be related to that exact factor that we just looked at sort of overall internalizing behaviors rather than teasing apart the true subscales that go into that internalizing behaviors. And that's, again, one of the things I plan to look at to break that apart more closely for within the ASD group itself. And then also, because we see with other measures that these data show that even typically developing children have higher rates of anxiety within this sample. So I do want to be able to look at that, not just using the internalizing factor.
Okay, great. Thank you.
Thank you.
Mary Beth asked in the chat, do you have teacher questionnaires in the older participants? And I was actually wondering if the older participants did their own self-survey as well.
So not as part of this study, though we do have teacher questionnaires that are related to looking at ADHD symptoms and concerns, but not anything that maps on their anxiety or other questions. And we don't have any individuals that are completing the school age visits themselves or their questionnaires themselves. It's usually parent reports.
Do you think for the parents, this is probably there's no way to answer this, but I'm wondering for the parents of the younger siblings of kids who have autism, if there's any kind of reporting effect on the CBCL because their child with autism maybe has externalizing behaviors, like a comparison effect.
Right, and I do think that's a great point because I agree that there might be something else going on in just the way parents are having the familiarity with autism and having that, the older child diagnosed with autism. Maybe there are influences related to, how parents are seeing different types of emotional behavioral challenges itself.